Hello, everyone. So today, we're going to do something a little different.
hmm
Usually when we start talking about transcranial magnetic stimulation, the focus, it immediately goes to the mechanics.
Right, the nuts and bolts.
Exactly. We're talking motor thresholds, finding the hot spot, coil placement, pulse frequency, all of it.
The how.
The how. And look, if you're listening to this, you probably already know the how. You're likely a provider, a psychiatrist, someone in the trenches doing this work every single day.
You don't need a manual on finding the DLPFC. You can probably do that in your sleep.
Right. But the source material we're looking at today, it's asking a much, much bigger question. It's not about the settings on the dial.
No, it's about the conceptual shift that dial actually represents.
We're looking at where TMS really sits in the modern mental health landscape. And I think the argument here is that it's not just another tool anymore.
It's not just another item on the menu.
We're talking about a completely different paradigm for treating mental illness.
Paradigm is really the key word there. I mean, the research we've pulled suggests TMS isn't just an alternative for when meds fail.
Or when a patient refuses therapy.
Exactly. It represents a fundamental move away from that single-track model to a layered, evidence-based framework.
Yeah.
It actually changes what we think we're treating.
And that is a huge claim, because for decades, that definition has been pretty static. But before we really unpack that, and there is a lot to unpack, we have to mention that this discussion is brought to you by the Blossom TMS team at www.blossomtms.com.
And that's really important because if you're a provider listening and you're looking for that innovative, evidence-based technology to implement what we're talking about today.
The Blossom TMS team is a resource you absolutely need to know about.
For sure.
Definitely check them out at www.blossomtms.com. They're doing fantastic work.
They are.
Okay, so let's get into this shift. You mentioned psychiatry has changed massively over the last couple of decades.
It has.
And I think when you're in the daily grind of clinical practice, seeing patients, dealing with prior auths, it's hard to see the forest for the trees.
You don't notice the water heating up around you.
Yeah, but the landscape really is different now, isn't it?
Oh, it's unrecognizable compared to 20, maybe 30 years ago. Back then, the model was pretty linear.
Right.
But the core thesis we're exploring today is that modern care is a layered, evidence-based framework. The whole mission is to see how TMS went from this fringe, alternative idea
to a conceptually distinct intervention.
Yes, one that totally aligns with this new systems-level thinking.
Systems-level thinking. I mean, that sounds great in a paper, but what does that actually look like when a patient walks into your office?
Well, it starts by taking apart the old narrative. We have to address the elephant in the room.
The chemical imbalance theory.
The chemical imbalance theory.
The old reliable, yellow serotonin, here's an SSRI. It's how the public understands it, and frankly, how a lot of us were trained to explain it.
Right, and it served a purpose as a metaphor. Yeah. But the source material, it makes it clear we're way beyond that now.
It's not a simple low-tank model.
The data just doesn't support it. I mean, conditions like major depressive disorder or OCD, they're now seen as disruptions in functional brain networks.
So it's not that the car's out of gas.
No.
It's that the traffic lights in the city are all out of sync, or the GPS is routing everyone into a dead end.
That is a much, much more accurate way to put it. We're talking about network-level brain models. The transition is away from just listing symptoms, sadness, lethargy.
And toward understanding the actual circuitry that's generating those symptoms.
Exactly. We're mapping the connectome, not just the complaints.
And this is where TMS comes in as the bridge.
Precisely. TMS is the bridge between all that complex, theoretical, neuroscience brain mapping, functional connectivity, and applied clinical care.
It's the practical application of the theory.
Yes. When you use TMS, you aren't just treating a symptom. You are physically interacting with the network itself.
I want to stick with an analogy here because I think it really helps.
Okay.
If the brain is a house, the traditional chemical approach, so medication, it's like changing the fluid in the heating system. You change the fluid, it goes everywhere, through every pipe, and hopefully warms up the cold rooms. But it affects the whole house.
That's the systemic effect. It's global. It heats up the bedroom, but it also heats up the basement and the attic, whether you want it to or not.
Exactly. But TMS isn't changing the fluid. TMS is fixing the wiring. It's going to the electrical panel, finding the specific breaker that keeps tripping, and flipping it back on. It's structural. It's electrical.
That is a perfect analogy because it really sets up the stakes. If the problem is the fluid, meds can work great.
Sure.
But if the problem is a trick breaker, you can pump all the fluid you want into the system.
The lights still won't come on.
They won't. And this is why we see so much treatment resistance.
Mm-hmm.
And this leads right into the next major point from our sources.
Yeah.
The 3 distinct domains of treatment.
Let's get into that, because I think patients, and honestly, even insurance companies, they think of treatment as a hierarchy. You try A, then B, then C.
Right. But this framework suggests they're actually different lanes on a highway.
Different lanes entirely.
We have to stop thinking of TMS as just a stronger med or some kind of techie therapy. It occupies its own lane. The source material breaks it down into 3 domains.
Okay, walk us through them.
So first, you have pharmacotherapy. Like you said, it influences neurotransmitter systems at a global level. It's systemic, brain, gut, liver, everywhere.
Which totally explains the side effect profile. It's not targeted.
Not at all. Okay, second, you have psychotherapy. This addresses patterns, cognitive, emotional through psychological processes. It's top-down.
You're using the thinking part of the brain to try and regulate the deeper emotional parts.
You're thinking your way to a change.
Right, which is powerful, but it relies on the hardware being functional enough to even process that insight.
That's the key.
Yep.
And the third is neuromodulation, TMS. It directly influences brain circuit function.
So it's not chemical, and it's not cognitive.
It's electrical and magnetic.
So it's not medication light, and it's not therapy plus. It's a fundamental third pillar.
The mechanism of action is what makes it different.
Yeah.
TMS doesn't rely on systemic effects. It doesn't wait for metabolism.
Or the blood-brain barrier.
Right. And it doesn't need verbal engagement like therapy. It uses targeted magnetic pulses to induce a current in a very specific group of neurons.
And that distinction, I think, is the aha moment.
It is.
It is a circuit-based intervention. If you're a provider listening, that's the language shift. You're not offering an alternative antidepressant. You're offering a circuit intervention.
You're offering to fix the wiring.
Yes.
And that matters because of the goal of the treatment. Which brings us to the difference between, say, symptom suppression and actual network regulation.
Okay, this is a pretty bold claim in the source material. It suggests that traditional treatments are often just about symptom reduction or even masking. Is that a fair way to put it? Or is that a little harsh on pharmacotherapy?
Well, it's a bit of a generalization, but it holds water when you look at the mechanism. Often medication turns the volume down on the distress.
It dampens the severity.
Exactly. But the source says TMS is rooted in modifying underlying neural activity patterns. We're not just trying to turn down the noise, we're trying to retune the instrument.
Can we get specific on the evidence for that? Because modifying neural activity sounds great, but what's actually happening in the brain?
The functional imaging studies are really compelling. The source points to abnormal activity in the dorsolateral prefrontal cortex, the DLPFC, in patients with depression.
Okay.
You usually see 2 things. Hypoactivity, so low activity, in the DLPFC, and hyperactivity in the limbic system, specifically the amygdala.
So the thinking brain is asleep at the wheel and the emotional brain is screaming.
That is the perfect way to visualize it. The DLPFC is supposed to be the brake pedal for the amygdala.
The top-down control.
Right. And in depression, those brakes are cut. The amygdala is just firing away, and the DLPFC is too sluggish to shut it down. TMS goes right after that DLPFC.
And it wakes it up.
It creates long-term potentiation LTP. The protocols are designed to normalize these activity patterns. By stimulating it repeatedly, you're essentially forcing those neurons to fire and strengthening their connections.
So you're jump-starting a car battery.
Or physical therapy for the brain.
I like that. Physical therapy.
You're exercising a specific neural node until it's strong enough to do its job again. It fits that biologically precise, mechanism-driven framework.
It's about network regulation, restoring the brain's own ability to regulate itself.
Exactly.
Which brings us to a huge pain point for providers and patients. The timeline, that linear model. You know the drill. Start with an SSRI, wait 6 weeks, increase the dose, switch to an SNRI, augment with something else.
And only after everything has failed, maybe 2 years later.
Then you consider TMS as the end of the line.
That linear model causes so much unnecessary suffering. It's an artifact from a time when we didn't have other options. And that's exactly the misconception we have to dismantle.
So break it for us. Why is it wrong now?
Because it assumes all depressions are the same. That it's a one-size-fits-all problem.
That there's one ladder everyone has to climb.
Right. In contemporary thinking, treatment is a toolkit. You pick the right tool for the job. TMS isn't a last resort. It's a targeted intervention for specific needs.
The source lists 3 modern framings for when to use TMS. I think this could give providers a real permission structure to use it earlier.
Absolutely. First, for patients with identifiable circuit dysfunction, if the clinical picture screams executive dysfunction, psychomotor slowing.
That inability to just get started on tasks?
Yes, TMS is a logical early line choice for that.
Why wait to fix the wiring if you know it's a wiring problem? If the brakes are cut, why are we changing the oil for 6 months?
It makes no clinical sense. Second, it's a non-systemic option for patients who are sensitive to medication side effects.
A huge group of patients.
A huge group. The weight gain, sexual dysfunction, GI issues. For them, TMS isn't a backup plan, it's the appropriate plan because it bypasses all of that.
That's such a massive quality of life issue. Patients stop taking meds because the side effects are terrible, then they relapse, and we blame the disease.
When really, it was the tool. And the third framing is that TMS aligns with long-term neuroplasticity models. If the goal is actual recovery, changing the brain's ability to adapt.
TMS is designed to do exactly that. It's using the brain's own ability to rewire.
Which means the big takeaway is mechanism over order.
Mechanism over order. I like that.
TMS should be defined by what it does, not its place in some arbitrary order set by an insurance policy from 1995.
I think that is going to resonate. But let's look at the bigger picture. Is this framework accepted, or is this still seen as novel?
You still hear people say, oh, that magnet thing.
Right.
But that's the final piece, evidence and acceptance. The source is very clear. TMS has transitioned from emerging to a recognized standard of care.
We are long past the experimental phase.
Decades past it. We have FDA clearance for multiple indications. This isn't hype. It's driven by large-scale clinical trials, meta-analyses, real-world outcomes. It meets the same thresholds as any other frontline intervention.
It's the convergence of neuroscience, clinical psychiatry, and technology all meeting in one place.
And it really speaks to this philosophy of the adaptive brain. It's a beautiful concept. We're not just managing a static pathology, we're engaging with a system that is capable of change.
Neuroplasticity isn't just a buzzword, it's the mechanism of recovery.
It's the engine of recovery. And looking forward, the trends are so exciting. We're moving toward personalized protocols.
Not just 5 centimeters and go.
No. Things like fMRI-guided targeting, where we look at the individual patient's brain map, theta burst stimulation for faster treatments. We're looking at new targets for anxiety, PTSD, addiction.
So the era of one-size-fits-all is ending.
It is. Precision intervention is replacing it. And TMS is at the forefront of that because a pill simply cannot offer that spatial precision.
You can't tell a pill to only go to the left prefrontal cortex.
But you can tell a coil to do exactly that.
So to bring this all back home, for the providers listening, the message is clear. TMS is not an adjunct. It's not a sidecar.
No, it's a core modality. It is the practical application of the neurocircuitry framework. If you believe mental illness is a disruption in brain networks,
And all the science says it is.
then PMS is the tool that directly addresses that belief. It aligns your practice with modern neuroscience.
And as we think about the tools we use, it's worth reminding everyone that for advanced solutions, you can explore the Blossom TMS therapy system by Siebers Medical.
Yes, definitely take a look at www.blossomtms.com. The technology is evolving just as fast as the framework, and you want to be working with equipment that supports this precision approach.
Before we sign off, I want to leave our listeners with that thought you had when we were prepping. It's a real provocation.
Right. So if we accept all of this, that psychiatry is moving toward neuroplasticity and circuit regulation, how does that change how we categorize mental illness itself?
What do you mean by that?
Well, right now we diagnose based on symptom clusters from the DSM. We say someone has depression or OCD.
Labels based on what the patient tells us.
Exactly. But if the treatment is targeting a specific circuit in the dorsolateral prefrontal cortex, are we moving toward a future where we don't treat the diagnosis at all?
You mean we stop treating depression and we start treating DLPFC hypoactivity?
Exactly that. Do we start identifying a specific circuit malfunction and treat that? Regardless of the label, we treat the biotype, not the phenotype.
We treat the wiring, not the name we gave the house.
Precisely.
Wow, that's a massive shift. That changes billing, diagnostics, how we talk to patients. It changes the whole identity of the field.
It does. But if the mechanism is truly the key, it might be where we're heading. It's something to chew on.
Something to think about as you head back into the clinic today. Stay curious, everyone.
Thanks for listening.
We'll see you next time.